Okay, welcome everyone. We have Dr. Les Podlog from University of Utah here today, and he's going to be talking about the psychology of injury rehabilitation and return to full function. So, Dr. Podlog, I will let you take over.
Okay. Yeah, thanks, Dr. Katana, for the invite. It's a real pleasure and to be with you all this morning, and I hope everything is well and everyone's healthy over in Pullman. I always enjoy the chance to meet and to present different ideas. So thank you for the opportunity to be with you this morning. As you can see, I guess from the picture on my title slide here, and as Dr. Katana just mentioned, I want to focus my discussion on some of the research that I've done looking at the psychological aspects of injury recovery and return to full function. As I go through some slides, please feel free to stop me at any point or interject with any thoughts or comments or questions, especially at a graduate class. It's wonderful to have some discussion. So just to briefly give you a little bit about my background, I'm actually a Canuck. From Canada, did my undergraduate and master's degree at Simon Fraser University in Burnaby, British Columbia, which is a suburb of Vancouver. As you can see from the photo, it's certainly a beautiful area, blessed with a lot of natural beauty. This was probably one of the few days where there was actually sunshine, because as nice as it is, it does tend to rain a lot. And after 8 years of being in Vancouver, I guess I sought sunnier pastures. And I was very fortunate to pursue my doctoral studies at the University of Western Australia, which is located in Perth on the west coast, which is on the Indian Ocean. And they have beautiful beaches and a wonderful climate. And so I was really fortunate to study sport and exercise psychology for several years in Perth. I then, my first academic position was at Charles Sturt University, which is located in a small community called Bathurst, which is about 3 hours west of Sydney. So it's located just outside the Blue Mountains. It's also quite a nice area, so I was able to work there for a number of years, for 3 years. And since then, I've moved around a little bit. I had a position, an assistant professor position at Texas Tech in Lubbock. I worked for a brief period of time as a research fellow at the German Sport University, which is pictured here on the far right. It's in Cologne. Cologne is a wonderful city on the Rhine River. And if you get a chance to visit Germany, I highly recommend it. It's a beautiful country. And for the past 10 years, I've been here at the University of Utah in Salt Lake City. And I truly appreciate the mountains here and love to get out and hike as much as I can. In terms of my research, my broad focus has really been in the area of health psychology. And within that broader focus, I've had three main areas of research or scholarship. The first relates to physical activity and exercise. And in particular, a number of previous doctoral students have looked at the impact of both resistance and resistance and aerobic exercise on things like on-task behavior among kids in schools, their cognitive function, and also their scholastic performance. And in a number of studies, we've shown that both resistance and aerobic exercise improves all three of those areas. And I think those findings have relevance, certainly, in a day and age where PE classes are being cut back, or, the rationale of policymakers is we don't have enough time to, do math and science, and we have to focus on those subjects. I think, these studies can potentially influence policy decisions to increase the likelihood that physical activity or exercise is maintained, and there's a rationale for that. Second area of my work is really kind of focused on athlete performance and well-being and some of the psychosocial factors that influence those two areas. I've collaborated with some scholars in Sweden in particular. We've looked at issues of burnout and what are some of the factors that contribute to burnout. So for instance, motivational factors, we've looked at stress or a lack of hope as potential variables that may contribute to this experience of burnout, where people kind of start to feel cynical or they no longer value their sport participation. And then my final focus, and this has really kind of been my primary area of research, relates to the factors, as I mentioned, that influence athletes' recovery and their return to sport after injury or to achievement activities. And so I want to focus my discussion more on that final area. I guess not to be too self-indulgent here, but my interest in the psychology of injury really stemmed from my own personal experiences with injury. I used to wrestle at Simon Fraser University, and I know for many people, when you hear wrestling, you think of kind of hyper-masculine, overly muscled individuals breaking chairs over their heads. But the sport of amateur wrestling is certainly physically demanding and very technical and tactical. The photo here was a teammate who I was fortunate enough to train and compete with. He became Canada's first Olympic champion in wrestling. He won the Sydney Olympics back in 2000. Unfortunately, I experienced multiple injuries. I had 3 ACL reconstructions, a shoulder operation, a dislocated elbow, a laundry list of injuries. And I found that it wasn't so much, while there were obvious physical incapacitations, I found particularly the psychological challenges of recovery and trying to get back in and compete at a high level to be particularly arduous. All these questions about would I be able to compete at the level I wanted to, or to achieve future aspirations, or worries about, whether my leg would hold up after, a long rehabilitation. And so these personal experiences really provided the impetus for trying to better understand, first of all, what are some of the factors that influence recovery and return to play, and whether there are strategies or interventions that can be conducted to enhance the likelihood that athletes not only make a full physical recovery, but that they're also psychologically fit and ready to return. So just to give you a little bit of context or background for the research that has been done on the psychology of injury, there's really 3 main areas that have been the focus of the bulk of the work in this area. And the first relates to the antecedents. In other words, what are the precursors or factors that increase the likelihood that an athlete gets hurt? Often we think that injury, acute injury, is simply a matter of bad luck, being in the wrong place at the wrong time. Maybe there's a physical collision where there's a clear attribution of injury. But more often than not, as I just alluded to, there's a specific cause or reason why injury occurs. And over the last 30 to 40 years, there's a growing body of research that shows that psychological factors can also increase or elevate the risk that an athlete gets hurt. And one factor in particular that's been shown to elevate or increase injury risk is stress. So I won't go into too much detail, but from a psychological standpoint, when you get stressed, we tend to get distracted, right? So you may have thoughts that are irrelevant to the task at hand, right? Like, I missed the last pass. What if I miss the next pass? Or, what is my coach thinking about me right now? I'm not playing particularly well. So when we have those distracted thoughts, when we're not immersed in the task at hand, it's not hard to see or to imagine how one might be more susceptible to getting hurt. There's also what we call, when we get stressed, we're also more likely to have a narrowing of the peripheral vision, right? So under stress conditions, we're less likely to be able to see peripheral cues in the environment. If I'm a quarterback, for instance, right, and like a linebacker is rushing at me, and I'm really stressed and I can only see straight ahead, I'm unlikely to see that individual coming from the side, and hence more susceptible to getting hurt. Okay, but there's also, as you know, physical consequences when you're stressed, right? Like your heart rate increases, maybe your muscles tense, you fatigue quicker, your timing and coordination become impaired, all of which can increase or elevate your risk of injury. Okay, so that's been one area of focus. Another, which I want to focus my discussion on more today, is this area of rehabilitation. And there's increasing body of work to show that motivational factors or confidence or factors related to the environment, to what extent is the individual getting social support, or do they trust their rehabilitation provider? Factors related to the rehabilitation environment as well as the individual that increase or that can impact the quality or effectiveness of the rehabilitation. Okay, and then finally, a third broad area of scholarship in this area relates to the return to competition. So that time frame when athletes are transitioning from the end of their rehabilitation and maybe they're engaging in more sport-specific forms of training or competition, and then full-on competitive activities. Okay, so as I say, I'm going to focus my discussion primarily on these latter two areas. And again, please feel free to stop or ask any questions as I go through some of the research in these two areas. Okay, so as I alluded to, in looking at rehabilitation, it's really the effectiveness or the quality, the outcomes of rehabilitation are really a product of two key factors. On the one hand, the athlete brings certain attitudes, beliefs, and behaviors that will certainly influence how the rehabilitation process unfolds. But it's also the case that the environment can certainly have a significant impact on how rehabilitation occurs. What access to facilities does the individual have? To what extent does the athlete or individual have access to good quality care, to knowledgeable, competent rehabilitation providers, physical therapists or athletic trainers? To what extent do they, as I mentioned, trust or support the care that they're receiving? Okay, and of course, there's always an interplay between these two primary factors. Okay. So I want to just briefly talk about a motivational framework or theory that really looks at the interplay between the individual, what they bring in terms of their motivation, and also the environment that can, on the one hand, foster or elicit individuals' motivation, but that can also work to suppress people's intrinsic or inherent motivation. Okay, and the framework that I'm going to talk a little bit about is called self-determination theory. And the reason I want to talk about this is because I think it will help you to understand the findings, the research findings that I'll talk about in just a minute. Okay, so one of the key assumptions of self-determination theory, which was advanced by Richard Ryan and Ed Deci, is that all individuals, regardless of culture, age, gender, that we all have three basic psychological needs, right? So just as we have physical needs, for food, shelter, physical things that need to be satisfied, we also have psychological needs. And a need implies that you have to have it in order to thrive or to experience optimal functioning. Okay, the first need, as you can see here on the lower left-hand side of the screen, is a need for autonomy. Autonomy implies that a person is volitional, or that they endorse what they're doing. I feel like I determine my actions. Okay. Sometimes people confuse autonomy with independence. That's not what Ryan and DC are really getting at here. You can autonomously or volitionally choose to engage in a task independently, or to engage in a way that's cooperative or interactive with others. So again, autonomy really implies this idea that you are determining your actions, you're in control of what you're doing. A second need refers to this notion of competence, the sense that one is capable or proficient in their endeavors, right? And people tend to like to do things that they're good at or that they're competent at. And then a final need is this concept or construct of relatedness. And sometimes, so relatedness refers to this idea of connection, right? We all as human beings need to feel connected to others. And, of course, the last year, I think, has been challenging for many of us because, unfortunately, we feel disconnected. Sometimes I ask students, just as an aside, whether anyone knows, or I'll ask you, does anyone know if someone's a prisoner of war, what's a common form of torture for prisoners of war? Does anyone know? What do they do to prisoners to undermine their psychological health? Or maybe even sometimes people in prison.
One way I've heard was that annoying songs will be played on repeat for hours and days on end.
Okay, so sure, that's one that can be pretty debilitating. Yeah, great. Other thoughts? You're right. Something related to this idea of connection.
Is it like solitary confinement?
You got it. Perfect. So, we tend not to do well when we're isolated from others, even sometimes for a brief period of time. And so this idea that connection is something that makes us more fully human is a basic assumption of this self-determination theory. Okay, now you can see in this diagram that the idea or the premise is when these three needs are supported, when your professors, when your parents, when your physical therapists provide support to help you feel autonomous, to help you feel competent or capable, and to give you opportunities to connect with others, that has beneficial implications for people's motivation. Now, I'll just in a second talk a little bit more about motivation, but you can see on the slide here, I have in this central circle the notion of high quality motivation. Typically, when people think of motivation, the idea is that it's how much people think of motivation generally in terms of the quantity of motivation, right? How energized am I in terms of pursuing my rehabilitation? But Ryan and DC suggest it's not just the quantity of motivation that matters for things like persistence or enjoyment of the task or how well we perform on that task. It's the quality of the motivation. And the quality refers to the reasons why people pursue what they do. Okay, so the basic premise here to summarize is when these needs are supported by significant or relevant others, it will foster or elicit high quality motivation, which will in turn lead to more positive behavioral and psychological outcomes. As I say, things like persistence, enjoyment of involvement in that activity, or a better performance. All right, so I just want to touch on one other central point here in terms of motivation, and then I'm going to get to some research findings. And in terms of the quality of motivation, I just mentioned that Ryan and DC suggest there are different types of motivation or reasons that underlie why you're doing anything in life: graduate studies, recovery from injury, trying to get a certain kind of job, whatever it may be. Okay, if we look here at the very bottom of the diagram, you can see that one type or form of motivation is called amotivation. And as the name implies or suggests, in this case, the individual is apathetic. They're maybe engaging in an activity, but they're, for all intents and purposes, going through the motions. They're not really invested in any way, despite the fact that they're doing it, right? In this case, the individual would be said to be low in self-determination, right? They don't really feel a sense of volition or control. They're doing it, but they're not really endorsing it in any way. So they're amotivated. Okay, I'll just go to the top of the screen here. Many of you have probably heard of this idea of intrinsic motivation, right? And the essence of intrinsic motivation is when you do something for the inherent enjoyment or love of the activity itself, right? I love playing soccer because I love the feeling of, dribbling the ball and, moving through the field, or I just love the feeling of mastering certain skills, or the excitement I get when I'm trying to compete. Right? The only reward you need is the participation itself, right? That's the essence of intrinsic motivation. And in this case, intrinsic motivation is seen to be the epitome of self-determination, right? Or that individual who's doing it because they want to and they enjoy it, or for the love of the experience, is seen to be self-determined, right? They're volitional. They're presumably, when you love something, you're doing it because you want to, you endorse it, and you choose to do it. All right, so those are kind of the two ends of the continuum. Now, in terms of extrinsic motivation, that's a third category or type of motivation. But as you can see, and as I'm going to just briefly explain, there are three different forms of extrinsic motivation that vary in their level of self-determination. Okay, so if we look here, external regulation, as the name implies, in this case, the individual is regulated or controlled by factors entirely external to the self. So for instance, the injured athlete is returning, maybe they're motivated to go through the rehabilitation and return to sport because they want to get a scholarship, right? Or they want to avoid a punishment. If they don't come back, they're going to get replaced on the team. Okay, so external regulation refers to regulation or regulated or motivated to engage in the behavior to obtain a reward or to avoid a punishment. Okay, in that case, we're fairly low in self-determination because, again, we're doing the reason that's underlining the performance or the behavior is because of something that's external to the self. Other factors are controlling or regulating the behavior. Okay, a second type of extrinsic motivation is referred to as introjected regulation. Okay, here, the regulation underlining the performance of the behavior is slightly more self-determined or internalized. So introjected regulation refers to when you do things to obtain internal rewards, like ego enhancement, or to avoid an internal form of punishment. So if we think about the injured athlete, that might be, well, I want to come back because if I don't, I'm going to feel really guilty for letting my teammates down, and I don't want to do that, right? Or if I come back, right, let's say I'm Kevin Durant and, my team is down, even though I've had an injury, I need to help tie the series against the Raptors so we can have a three-peat, right? I'm going to feel good about myself because I'm a true athlete and competitor. And that, is something that a real athlete does, right? So I'll feel better about myself. My ego will be enhanced in some way. Okay, so in this case, you're slightly more self-determined when you're introjected, but you're still, in essence, doing something for a reason that's fairly external in nature. It's not just that you love to do it, right? Okay, the last form of extrinsic motivation is called identified regulation. And as the name implies, this is when the individual personally values or identifies with the regulation that underlies their behavior. So the athlete who really wants to help their team win, right? Like winning is something that's maybe personally endorsed, heavily identified with and valued. In that case, you're still doing it for an outcome to help the team win, but that could be said to be different. You're coming back for a slightly more internalized or self-determined reason than if you're doing it entirely to obtain a reward or to avoid an external punishment. Okay, so any questions on that? Hopefully, does that make sense? All right, so with that in mind, I'm going to talk about some studies that are based on this framework. One of the recent bodies, I guess, a series of studies that one of my former doctoral students, Morgan Hall, conducted was to develop inventory or questionnaire to assess the need, or to assess, the extent to which injured individuals felt that a relevant other, in this case their physical therapist, was supporting their basic psychological needs during their physical therapy or during their rehabilitation. Okay, and we framed the development of the questionnaire based on this theoretical framework that suggests the value of having athletes' need for competence, autonomy, and relatedness supported for their motivation and subsequent behavior, things like their adherence or compliance. Okay, so what I put up here is a list of some of the specific questions on this inventory that we recently published. You can see as an example of some competence items, okay, one question asked the individual, I feel that my physical therapist provides me with exercises that I can realistically achieve, right? So if you feel like you can realistically accomplish something, that's probably going to enhance your sense that you're capable or competent. On the other hand, if you're being given tasks that are far too difficult, that could undermine your sense of competence, because it's like, I just can't do this. Maybe there's something wrong with me, or I'm just not good enough, that kind of thinking. These first four questions relate to this idea of competence, right? I feel that my PT helps me feel capable of doing challenging exercises, or about my ability to complete exercises. In terms of autonomy, you can also see that some of these items try and get at this notion of what it means to be autonomous. So one of the great ways that we found in research that practitioners can help an individual feel autonomous is to give them a sense of choice. Because if you choose to do something, right, like I chose that shirt this morning, or, like I chose this, strength training task, right? Then you're more likely to feel volitional because you've opted to do it. When you feel part of the decision-making process, or when you feel like you have the opportunity to express what's on your mind, you tend to be more inclined, or you tend to have that feeling of autonomy reinforced or validated. Okay, and then finally, the relatedness items are things like, I feel like my PT tries to develop a caring relationship with me, or to make a connection with me, and to make an effort to get to know me and my goals. So this is an inventory that could be used in a practical setting. It's quite concise, and the practitioner could give that to the athlete to get a better sense of how do they feel about their level of support during their physical therapy. Now, then the question is, okay, well, so what? The individual feels supported. What, if any, implications might that have for their motivation to engage or to comply with the rehabilitation? And presumably the logic of the field of physical therapy or athletic training is, if you do these exercises, you're going to get better, right? If you adhere or comply with the prescribed regimen, it will elicit positive rehabilitation outcomes. Okay, so in terms of this question about motivation, right, and do these notions of competence have impacts on motivation? In another study back in 2005, my former doctoral supervisor, Bob Eklund, and I looked at this issue of motivation to recover from injury. And essentially, we're curious in why is it, what's driving athletes to endure what may be a potentially long and arduous recovery and to return to sport. So what we did was we collected data from 180 athletes from 3 countries, from Canada, England, and Australia. And we gave them an inventory or questionnaire called the Sport Motivation Questionnaire. And so we slightly adapted it to ascertain why the athletes were trying to, or what their motivation for recovery and return to sport was. And then we also gave them another questionnaire that assessed their perceptions of how they were performing after their injury. Because remember, according to this theoretical framework, self-determination theory, the reasons why you do something should have implications for things like your performance. So in this case, we wanted to see whether their motivations for recovering were associated with different kinds of outcomes post-injury once they started competing. Okay, so if we look at the diagram here, you can see on the horizontal axis or the x-axis, you can see I've listed the different types of motivation that I previously described just a minute ago. Okay, so let's just have a look here. Let me try and orient you a little further. The mean scores, the average scores, the athletes completed this motivation scale. It was a 7-point Likert scale. So 1 being low on a certain kind of motivation, 7 being high, the highest possible. Okay, if we look at these latter 2 bars here, this IMS refers to intrinsic motivation to experience stimulation. So I didn't really get into this, but essentially there's different types of intrinsic motivation. And you can see that the athletes, these were high performance athletes, so many of them were either earning some income or maybe had a scholarship. They were competing at collegiate or professional levels. But even though they were athletes who, were generally competing in externally rewarded environments, you can see that they scored highest on this intrinsic motivation to experience stimulation and on the intrinsic motivation to experience accomplishment. Okay, they were slightly lower in their mean scores, kind of around a 4.5 out of 7 on identified regulation. Again, so where they feel like maybe they're coming back because they want to win, as an example. Slightly lower, or the lowest forms of motivation were those 2 kinds of extrinsic motivation that I mentioned, introjected regulation and external regulation. Okay, so this suggests that, again, even amongst high performance athletes, it may be the case that intrinsic motivations are important or perhaps even requisite, maybe even needed, in order to drive athletes to overcome all of the tedium, the challenges, the hurdles associated with the recovery. Okay, now, we also, as I mentioned, asked them about their post-injury performance. Now, it can be very difficult to assess, to have like standardized or objective measures of post-injury performance when you need a large sample to run the statistics and you have athletes competing in a variety of different sports, right? So we had, rugby players, ice hockey players, swimmers. What performance looks like in one sport may vary significantly from another sport. Okay, so in this case, what I did was developed a questionnaire called that assessed their perceptions of their post-injury performance. Okay, what we found was that intrinsic motivation was positively associated with what we termed a renewed perspective on sport. Okay, so this renewed perspective was indicative or reflective of positive outcomes, things like greater mental toughness after the injury than prior to it, or heightened motivation for sports success, or more positive perceptions of one's performance. Okay, on the other hand, we found that extrinsic motivation also had relationships, but in this case, the positive relationships were with what we referred to as return concerns. This was more indicative of negative outcomes. Things like statements like, to what extent are you worried about getting re-injured? Or do you have performance anxiety? Or do you feel that your performance are diminished after your injury in relation or compared to before your injury? Okay, so the take-home message here, and this is, of course, is just one study, but I think it suggests that motivation may have important implications for the quality or the types of performances that athletes are having post-injury, right? And so, as a practitioner or as a physical therapist, it's worth at least considering or paying attention or having some discussions with the athlete about why are they doing this? What is driving them? To have some awareness that depending on those reasons, that may have some implications for how they return or what their performance is like once they do return. All right, so I want to just talk a little bit about some research that focuses on another psychological construct that I've been interested in recent years. And it relates to this idea of efficacy, or what we've referred to in psychology as a situation-specific form of self-confidence, right? So you probably all know from your own experience that when you believe in your abilities to be successful on a task, that may generally have positive implications, right? Like, it's logical that if you believe you're going to be successful, that maybe you're going to work through challenges, or maybe you'll start a difficult task, right? You're maybe going to be more likely to persist when things get difficult because you believe, well, I'm capable of doing this, my hard work will pay off. Okay, that all refers to this notion of self-efficacy, right? Your belief in your personal ability to be successful on a task. There are numerous studies, not just in the area of rehabilitation, but in a whole host of achievement domains, that show the importance of self-efficacy beliefs for a whole range of downstream outcomes. Okay? But an exclusive focus just on this idea of personal beliefs in one's ability misses the fact that much of how we develop our sense of confidence, our sense of ability, is developed through our interactions with others, right? Our parents, again, our teachers, our physical therapists, or athletic trainers. Okay, so often these dyadic relationships can have significant bearing on how we, believe in our own abilities. Okay, and when we're interacting in those relationships, we're forming judgments or evaluations, not just about ourselves, but about the people that we're working with. Okay, so in this Tri-Partite Efficacy framework, Lent and Lopez proposed two additional efficacy constructs in addition to this notion of self-efficacy. Okay, the one I have here in this middle box is called other efficacy. And this relates to the extent to which an individual believes in the competence or ability of a relevant other. Do I think that my PT or athletic trainer knows what they're talking about? Presumably, if I trust their competence, if I think they're smart and knowledgeable, maybe they're an effective communicator, I really think that they know what they're doing, I'm probably or presumably going to follow their instructions or their prescriptions and advice. Again, if I do that, assuming that individual is in fact, knowledgeable about the literature, they know the programs, that by following or adhering to their prescriptions, that will, in theory, have positive outcomes, in this case, let's say for your rehabilitation. Okay, so this notion of other efficacy is a second judgment or belief that people form, again, in relation to relevant others. Okay, now there's a third construct that I just want to clarify called relation-inferred self-efficacy. Relation-inferred self-efficacy. This relates to the extent to which you as an individual make an estimation of whether you think others believe in your competence or your ability. Do I think my coach believes in me? Do I think my PT really is, convinced that I can meet the challenges, rise to the challenge, and make an effective recovery? Okay, I can tell you, I remember from personal experience, just very briefly, after I think I had dislocated my elbow and I was trying to come back. We competed in the NAIA at the time. And I remember one of my coaches saying, you need some matches. You need to get out and, compete. And while he was right, I didn't really feel like I was ready because I had only had a couple practices. And, 5 weeks earlier, my forearm was essentially disconnected from my bicep. And so, I remember thinking, like, he was just shaking his head. And I remember him thinking, he thinks I'm just wimping out. He doesn't believe in me. And it really had a negative impact on my own confidence. Okay, so as individuals, you're making an estimation of whether you think others believe in you. And again, presumably, if that's the case, if you think others do believe in you, you're more likely to engage, in this case, in behaviors such as adherence. Okay, so I want to talk a little bit about, again, with sort of that as a bit of a background, I'm going to just talk a little bit about a particular couple of studies that one of my other doctoral students, Lindsay Graviscus, did, in this case, not with athletes, but we looked at patients with Parkinson's disease, a neurological disease where the aim of rehabilitation isn't necessarily to improve, but even just to maintain a certain level of function, given the sort of progressive decline that characterizes this disease. Okay, so in this study, we had a little over 70 individuals. It was a quantitative study, and we wanted to look at this idea of the extent to which individuals, these patients with Parkinson's, felt that they received care from their practitioners. To what extent was the environment one of caring, and whether that would have implications, whether that would foster or increase their tripartite efficacy beliefs, which in turn we predicted would increase their adherence to the rehabilitation program. Okay, now by caring, a caring rehabilitation climate, in essence, refers to this idea that people feel valued, respected, and the fact that their relevant other, their PT in this case, has their best interests at heart, or puts their interests front and center in their interactions. Okay, so just briefly, I'm just going to highlight in a qualitative study. We interviewed a number of Parkinson's individuals with Parkinson's, and we asked them, we wanted to explore a little bit, first of all, what does this idea of caring look like? Like, what does it mean to be in a caring rehabilitation environment? Okay, so they talked about things like, well, I know my physical therapist cares when they do things like show interest. That could be by remembering information, or simple things like just talking to me and asking questions about, like, how am I doing? What do I want to achieve here? How does the rehabilitation fit into my life? When they did things like creating a supportive environment, right? It could be, again, small things like just making the person feel welcome, being friendly, or feeling like their needs are supported. A few other things they talked about was this idea of benevolence, right? That they had a warm or positive experience, and their practitioner seemed invested in their job. They weren't just there to kind of, do their job, but they really seemed like they cared about their work. And I think that probably applies to lots of things, right? Most of us like to be around people who seem enthused, passionate, if you will, about their work. And then they also talked about this idea of paying attention, right? Like simple things like getting one-on-one attention, or having someone give them feedback where their technique was getting corrected. Okay, so all of these things were said to be reflective of this idea of caring. And then the individuals in this qualitative study also self-reported that when they felt cared for, it had positive implications for their adherence or their recovery. But this was simply a qualitative study. So we wanted to explore those quantitatively. Okay, now in this study that I alluded to, the quantitative study a minute ago, we looked then at these relationships between caring, the 3 efficacy beliefs that I mentioned just a minute ago, and adherence. Okay, so let me just walk you through this diagram a little bit here. Okay, our reasoning or our line of thinking is that if someone demonstrates care, for instance, if they're willing to spend time or to show me a corrective information, that will presumably increase my own belief that I can accomplish something because they're showing me what I need to do. Therefore, I'm more confident that I can do it and therefore more likely to adhere to the program. Okay, we also reasoned or suspected that if someone is willing to, spend time, make the person feel welcome, or, again, demonstrate not, corrective information or spend time, that I, as a patient, am more likely to believe that they're competent if they're doing all of these things, right? That's what a good practitioner does, right? So we suspected that higher levels of caring would predict greater levels of this notion of other efficacy. Okay, and then finally, we reasoned that if the individual felt that they were cared for, it would also have positive, or it would positively predict this notion of RISE, relation inferred self-efficacy. So again, if the individual is, maybe willing to spend all this time, energy, and effort with me, then maybe I'm likely to think, well, the reason they're doing that is because they believe in my ability to recover. Why else would they spend all this time, energy, and effort on me? Okay, so if we look at this diagram, what we can see, again, we predicted that caring would positively predict each of these 3 efficacy beliefs, which in turn would positively predict adherence. Now, if we look at the what's called the beta coefficients for this A path from caring to each of the efficacy beliefs, what we found supported our prediction. In other words, the more these Parkinson's patients felt cared for, the more each of these efficacy beliefs were increased. Great. Okay. On the other hand, in terms of this, what we refer to as mediation, where it's not simply the case that caring directly predicts adherence, but that the impact of caring on adherence is through or via these mediating variables. Okay, we didn't find support for this notion that these 3 variables, the efficacy variables, then predicted adherence. But here's the thing. What we found was each of these 3 efficacy variables were highly correlated, right? And that's consistent with other research, where if I believe in myself, right, or if I believe that, in the competence of others, that's likely to have positive implications for my own belief. I'm working with someone who's good, therefore I believe that, if I follow what they say, I'm going to recover. So my own efficacy goes up. Okay, so generally these 3 efficacy constructs tend to be related, and that was also the case in this study. So what we suspected was that there were what's called suppression effects. In other words, because these variables were highly correlated, we suspected that the impact of one variable was essentially canceling out the effect of the other in terms of its predictive effects on adherence. So the solution was that we ran separate mediation analysis with each of these efficacy variables as a mediator. And what we found was that in this case, caring then positively predicted relation inferred self-efficacy. In other words, again, if I felt cared for, I was more likely to believe that that my PT believed in my abilities. Okay, and when that was the case, when relation inferred self-efficacy increased, so too did adherence. Okay, so these findings suggest that small, simple things, right? Saying hello to someone, asking them a few questions about what they want to do, right? Like by engaging or trying to maximize the interaction, right? Like physical therapists or athletic trainers, they often say, I don't have a lot of time when I'm interacting with these people, right? I have 15 or 20 minutes, then I got to move on to the next patient. So I would say all the more reason why it's important to optimize the quality of that interaction. And I guess what I love about these findings, or what I find interesting about kind of social psychology, is there's small, these research findings suggest there's small little things that you can do when you get out into the world and as you're working and interacting with patients, for instance, that can demonstrate care. And as these findings suggest, when you do that, their efficacy beliefs may go up. And if, as I've just mentioned now, if their sense that you believe in them increases, maybe they're more likely to adhere to what you're saying. Okay. All right. So these studies suggest that psychological factors can and do potentially impact what's happening in terms of rehabilitation. Okay. And so when we know, as psychological researchers, when we know that motivation or confidence, for instance, can influence recovery, then the task, or then a logical next step, is to see whether modifying or trying to shape those factors that we've identified as predictive or relevant to outcomes can be impacted in order to increase the likelihood that we bring about certain kinds of outcomes, right? Where people have holistic physical and psychological recovery. Okay, so I want to just on that note talk a little bit about an intervention study that we recently published involving a fairly small sample of 16 athletes here at the University of Utah, okay? And essentially our question of interest was, does receiving a psychological skills program, if athletes get what we refer to in sports psychology as mental skills training, does that impact three things: their well-being, again, their adherence, and then lastly, their clinical function. Okay, so I want to just talk a little bit more about this intervention study that we did. As I mentioned, we had 16 athletes. They were all from the University of Utah, so they were Division I athletes, 4 males, 12 females, and we required them to have a minimum of 4-week absence from sport training or competition, right? We wanted to have athletes that had at least a relatively serious injury. Okay, they had injuries like ACLs, stress fractures. On average, the mean absence was 12 weeks or more. So, you know, these were all athletes that were out for some significant period of time. Okay, what we did was we implemented a quasi-experimental design, and I'll explain that here in a minute. Okay, we had 8 athletes enroll in our experimental condition where they did their physical rehabilitation, their sort of traditional or rehabilitation as prescribed by their treating athletic trainer. And then we gave them 4 specific skills that I'm going to talk more about. First of all, we wanted to give them some education about their injury. The idea here being knowledge is power. If you are uncertain about something, that tends to be a universally aversive state. On the other hand, you're more likely to feel autonomous or in control if you know what's happened to your body and you understand here's what's the sort of path to recovery, right? We're going to explain how things are going to unfold. So we wanted to provide them with education, some tools to help them manage their emotions, which are notoriously may have negative moods and frustrations, to help them manage their pain, which certainly in the immediate aftermath of injury can be very debilitating, and to give them some tools to help them focus on things that they can control. As I talk about the skills, you'll see I'll highlight a little bit more how they're related to the 3 psychological needs that I just mentioned. Okay, so we had 8 athletes in the experimental group, and then we enrolled 8 athletes as controls. And so these athletes just completed their physical rehabilitation. Now, I mentioned we used a quasi-experimental design, right, rather than an experimental design. Ideally, when you're conducting research, I'm sure as you've maybe been speaking with Dr. Catena this semester, right, you want to know that the independent variable is causing a change in the dependent variable, right? And one of the ways to do that, of course, is to randomly assign individuals to different groups, okay? We would have done that in this case, but were it not for the fact that these athletes were rehabilitating in the same environment, and we wanted to avoid what's referred to as contamination effects, where the athletes who are getting these skills could potentially be hanging out with their mates in physical therapy, and maybe they share information, or they say, hey, try this. I'm, got this mental program that I'm working through for my rehab. Why don't you use that? So what we did was, to avoid that situation, we first enrolled, we first enrolled 8 athletes in the experimental group. Then when they were finished their rehabilitation, then we sought to enroll 8 controls. All right, now just briefly in terms of the skills, and I'm happy to share some of this content with you. I know Dr. Catena mentioned there's maybe some of you are working in practical settings, or I don't know if there's other faculty listening or some athletic trainers. But my colleague, John Heil, who years ago, back in 1993, wrote the first book on the psychological aspects of injury, developed some injury education guidelines. And basically it's a heuristic that has, as you can see, some different bullet points. So it could be things like the anatomy of the injured area, changes caused by the injury, what are some methods of rehabilitation, or how is it that rehabilitation promotes healing and recovery. So this isn't the full list, but basically the idea was we had the athlete take the list and they would go to their treating athletic trainer and they would just use it as a guide to have some conversation to make sure, to increase the likelihood that they were knowledgeable about their recovery. So when they did that, the idea was that would give them a greater sense of competence because, right, they're gaining knowledge, so they feel more competent or capable. And then also, of course, through that interaction or through that exercise, it fostered some sense of connection with their treating athletic trainer. And then they came back the following week and they had a discussion with the graduate student who was carrying out the intervention or helping implement the different skills. Okay. In terms of emotions, as an example of one of the strategies we used, there's a technique called emotional disclosure. And in essence, it's basically getting people to journal or write down a diary. A guy named James Pennebaker at the University of Austin developed the technique and to help individuals like soldiers, people who'd suffered trauma and PTSD, to help them come to terms with their experience. And the essence of the idea is, if you avoid it and try and suppress what you're experiencing, you're not really dealing with it. So you have to kind of work through it. So we gave athletes sort of some questions to help guide them through the kinds of things that they could write down, like what's been difficult for you about this injury, or what are the things that you miss most? What goes through your mind as you lie down at night before you go to sleep? Those kinds of things. Okay, so that was an exercise intended to help them work through their emotions. Again, it gives them a sense of control. And then when they would meet and have some discussion with the graduate student, that again fostered a sense of connection. We gave them imagery, a relaxation and imagery script. It was an audio recorded script that helped them to manage chronic and persistent pain. So they were encouraged to listen to that on a daily basis. And then finally, we gave them some exercises focused on distraction control, right? Like, I don't know about any of you, but my mind wanders constantly throughout the day, right? And so this skill of, it's kind of cliche, but focusing on the things you can control, trying to, minimize your focus on that which is out of your sphere of influence. We gave them an exercise here, for instance, where they would simply write down their concerns. They would list solutions, and then we tasked them with writing down some pros and cons to each solution. So, if the athlete says, well, I like to drink heavily, well, that's one solution maybe to dealing with physical pain. Maybe there's some upsides to it, but there's probably also some significant downsides, right? So the idea was to think about, well, what are some behavioral things that I can do, task-oriented things that I can do to address these concerns, and then again, to adopt the solutions, or they were encouraged to adopt the solutions with more cons and fewer, or more pros, and fewer cons. All right, so here's what we did in terms of the study. At time one, when they were enrolled in the study, or when they were enrolled in rehabilitation, within the first week, we assessed these 3 outcomes of interest. In this case, there were 2. The well-being, which I mentioned. So we used validated measures to assess their positive and negative affect or emotions, their vitality or their level of energy, and their self-esteem. Okay, and then we also assessed their clinical function using a tool called the Oswestry Disability Index. So these are all sort of validated and reliable inventories to assess our outcomes of interest. Now, we also wanted to assess adherence, but given that they hadn't even started rehabilitation yet, there was no adherence to actually assess at this point. We did, however, assess all 3 of our outcomes of interest at time 2, which was at the midpoint of their rehabilitation. So again, we gave them the same inventories, the well-being measures, the clinical function, and then also the adherence. In terms of adherence, we asked the practitioners or the treating athletic trainers to give their perception of how adherent the athlete was. So the treating ATs completed the adherence measure. And then we gave the same 3 measures on a final time point once the athletes were medically cleared to return. All right, I'll just briefly highlight a few findings, and then I guess we can leave it at that, or I'll offer a few concluding thoughts. This figure here shows results for their positive affect or positive emotions at the 3 different time points. So again, at time 1, when they first entered into rehabilitation, on this 7-point Likert scale, they were relatively low or moderate in terms of their positive affect. You'd expect that because they just were recently injured. Okay, both groups were equivalent. So I should say here, the dotted line represents the intervention group, and the straight line represents the control group. Okay, both groups, as I say, at time 1 were relatively low. There were no significant differences. You can see over the course of recovery, both groups trended positively or experienced increases in their positive affect as their rehabilitation progressed. That seems to make sense given that they're, presumably improving and moving towards recovery. We found that there were significant differences, however, between the intervention group and the control group in terms of their positive emotions, both at time 2 and at time 3. So the intervention group experienced significantly higher positive affect at the midpoint of their rehabilitation and again at the end of their rehabilitation. And we had similar findings when we looked at negative affect. In this case, negative affect decreased for both groups over the course of rehabilitation. The intervention group had significantly lower negative affect at time 3 when they were medically cleared. And then the last slide I'll show is their vitality, right? Again, vitality was low in both groups. At time 1, when they entered into rehabilitation, their scores were fairly similar, but improved over the course of rehabilitation. In this case, both at time 2 and time 3, the intervention group had significantly higher vitality scores. Okay, so, at least in terms of their emotions, these findings suggest that, as practitioners, things can be done to improve their emotions. And emotions can be powerful drivers of behavior or can have a powerful impact on your experience of something. So I guess I'll skip over a few slides, but I'll just offer a conclusion here and to suggest, apologies for going over time, to suggest that psychological factors do influence rehabilitation and return to sport. I mentioned some evidence that these interventions can enhance recovery, certainly from a psychological standpoint. And as I highlighted, there are different inventories that can be used from a practical standpoint to assess athletes' psychological status. I'm happy to, share any information or to discuss, any of the findings or, I can share slides if you like.
All right. We've had quite a few have to skip out already. But I have a question for you. So I'm trying to separate out, or maybe I'm incorrectly trying to separate out this idea of motivation to get back to competition, or lack of motivation to get back to competition versus motivation to adhere to my rehabilitation process, to listen to my AT, PT, whatever they say. That's what I should be doing. These aren't mutually exclusive, I guess, but there's a kind of different paths there. So maybe you could comment on that.
Yeah, sure. No, that's a great point, right? So that I would agree with your statement. There is a distinction between your motivations to return to sport and your motivations to comply, or maybe absence or dearth of motivation to comply with rehabilitation recommendations. And, I think your point is important because one needs to consider what are you interested specifically in examining, and then to ensure that the questions, or in this case, if you're giving a questionnaire, to ensure that you're actually tapping that which is of interest. So if I'm, like in this case, I mentioned motivations to recover. I think the questions actually, maybe that was, I probably could have labeled that actually better, to your point, because in fact that the motivations, the questions here really were about like why they wanted, in this study was about why they wanted to come back to sport, which is different. Like we were, the STEM at the stop said like, what something like basically what is it that's motivating you to come back to your sport, right? So that's different than what's motivating you to listen to your rehabilitation practitioner. And I think you're right. There's a distinction. They're probably related in some ways. Like maybe if someone is, they understand that listening or being motivated to engage in their rehabilitation or to listen to their practitioner may also relate to their ability to return to sport. There's probably some connection there, but you're right. I think they're distinct things. And so again, one has to be careful about what they're actually assessing and whether what they're assessing taps into what they're trying to assess. So yeah, that's a bit of a long-winded answer, but.
This is Dr. Morgan, Dr. P. Hey, how you doing? I had my video off, just listening to you. We're multitasking, but just like right here. And I appreciate what you have to say. In addition to my duties here at Washington State, and Dr. Catena knows this, I've coached for many, many years, and my passion is coaching principals and whatnot. And it's basketball, football, whatnot, but I've coached a number of other things at the interscholastic level, secondary.
Yeah.
And I don't want to just boil your study down to I'm aware of self-determination theory and intrinsic motivation and whatnot, and you've looked at it from another perspective, and I know there's a lot of research on it, but it's a great reminder that I keep seeing over and over in at least the secondary education ranks in terms of motivating athletes, and not necessarily coming from injury, but just general performance anyway. Sports psychology, what it is. So I found that very, very fascinating. I really liked your story about you being the wrestler at Simon Fraser. I think that's where you got injured, right? You had all your injuries. And if people don't think wrestling's a rough sport, just talk to you. Right? Jeez. And your perception of the coach's expectation of you and how powerful that is, and especially the younger I think an individual is, and the more credible they perceive the coach to be, whether it's age or experience, etc. And what a powerful driver that is. I think you would agree, right?
For sure. Yeah, for sure. And I mean, I think that's a great point you mentioned, Dr. Morgan. Like these effects could also certainly be age related, right? Like, when you're, I don't know, a little bit older, maybe you have your more secure sense of self, right? You're maybe a little bit less susceptible, you could say, to concerns about, how other people might be perceiving you, or you might say, oh, well, they can think whatever they want about me, but, like, I'm not ready yet in this case. Or, like, whereas when you're younger, when you're late teens, early 20s, those coaches can certainly, as you know better than I probably, can exert a huge influence, right, on your sort of sense of self, your self-beliefs. I guess these studies, in some ways, I guess, we necessarily target like a specific factor, but there's probably a whole multitude of things that influence, in this case, your efficacy beliefs, right? Like, what kind of relationship do you have with your coach, maybe, for instance, prior to an injury? Like, if you have a really good coach-athlete relationship, maybe you're more likely to believe that, even if you're going through a tough time, they still believe in you, or, that you still believe in them because they'll do things that make them a good coach, or they'll reach out to you, again, just relating it to injury, even if you're hurt. So I agree. I think there's a lot of things in terms of the dynamic between the coach and the athlete that, or factors related to the athlete, their age, all kinds of things that impact these specific concepts or beliefs, for sure. That's a great point.
Exactly. And there's always a lot of variables, right? Background, whatnot. And I don't want to take all this time because, Robert, you probably got to go. I'm not a grad student, but I like these. I love these talks that Robert brings up. I'm like a lifelong learner, right? Cognitive behavioral therapy. What a find, right? What an intervention. I've just heard so many things over the years, and I saw it within your study there. So
well, I'm happy to send you, detailed publication or some information like from the skills that I touched on. And that's exactly kind of what we had some comments from reviewers saying, well, like, I don't know if you're really meeting these needs. So we sort of said, well, in essence, this is a cognitive behavioral intervention. And that's kind of how we ended up framing it more in terms of the publication. But you're right. Like, I think, sometimes just simple things in terms of how you help athletes to maybe question what they're thinking, or to just realize, well, it's just a thought. It doesn't have to be sort of, as big as it's being made to be, or, getting them to reflect and to be aware of what are their thoughts, how do those thoughts impact them positively or negatively. I guess the reality is probably coaches are probably among some of the best psychologists, really, because they're putting these things into practice all the time.
Yeah, good and bad, right?
Yeah.
It's all around. The sword cuts both ways.
Right.
And even in positions that you and I and Robert have, you know, I have to take a step back and realize the power we hold over the motivation of our students, even in these particular settings. So, well, hey, I don't want to delay you, but Robert, thank you for bringing on another great speaker.